Hello, all. Let us learn about diagnostic stewardship in fungal infections. Diagnostic stewardship in fungal infection. Let us understand the burden. 25% of the global population suffer from superficial fungal infections. Invasive fungal diseases incidence is up to 1 to 12 per thousand. More than 3 million individuals encounter severe fungal infections globally, with mortality of more than 1.6 million annually. The incidence and epidemiology of invasive fungal diseases is expanding in critically ill or immunocompromised patients and are associated with significant morbidity and mortality and costs. Need antifungal stewardship. Through cases. Case 1. 55-year-old female, diabetes, dyslipidemia, hypertension, smoker, COPD, on steroids on history of tuberculosis 10 years back. Now history of fever on of low grade fever for 2 4 weeks. Patient complaints with breathlessness, weight loss, cough with expectorations. Chest X-ray showed emphysematous lung. CBC showed a high total leukocyte count. ESR was raised up to 130. However, the sputum for AB was negative. CT showed cavitated pulmonary lesions in the lower unilateral, similar small cavitated lesion in lower lobe with associated traction bronchiectasis. Remaining lung parenchyma, ground glass, and patchy central lobar nodules were seen. Oxygen was 2.5. The patient was started on antitubercle therapy empirically. However, there was no response. The patient continued with fever, shortness of breath. Now, what's next? Are we missing something? Is bile analysis needed? Differential diagnosis for this case will be bacterial infection, tuberculosis, viral or fungal infections. Fungal infection could be either because of aspergillosis, mucormycosis, pneumocystis, penicillium, histoplasmosis, or cryptococcosis. So it's necessary to investigate to the differential diagnosis in such cases. 45-year-old female vegetable seller with complaints of itching at the back, trunk, arm for 5 years. She was using some fairness cream. She was non-diabetic. HIV was negative. On examination, there were extensive lesions on the face, buttocks, trunk, face, and arms as shown in the slide. Differential diagnosis. And how will you diagnose? Let us see this interesting article, which is on topic of steroids awareness and misuse among patients, pharmacists, and general medical practitioners. It is observed that out of the total 44 general practitioners enrolled in the study, 50% were qualified medical practitioners and 50% were homeopathic or average doctors. Superficial dermatitis was a common dermatitis seen by them, while 65% preferred prescribing topical steroids or in combination, rest of them preferred steroidal creams. 41% did not have appropriate knowledge of topical steroids. 19% were not aware that steroids are unscheduled H drugs. Commonest molecule sold over the counter was clopidogrel propionate. So, as dermatologists, it is a responsibility to correctly educate the society, particularly the non-dermatologic medical fraternity. So, that was the observation and antifungal stewardship. 7.7% of the ICU admission in the United States are associated with prescription of systemic antifungal. 30 to 50% of the antifungal prescription could be optimized. Antifungal treatment associated with significant toxicity, emergence of resistance with poor patient outcome. Considerable economic burden is another concern. For antifungal stewardship. Clinical acumen to recognize commonly superficial fungal infections. Diagnosis to support to establish timely diagnosis and when to start antifungal and what to stop. Just take a minute to observe this slide. Well, let us classify the fungal infection before we proceed to in detail about diagnostic stewardship. It can be either superficial mycosis, subcutaneous mycosis, or systemic mycosis. Superficial mycosis affects skin, hair, nail, mucous membrane. Subcutaneous mycosis affects deeper layers of the dermis, subcutaneous tissue or bone. Chronic or insidious growth pattern initiated by trauma to the skin. Then systemic mycosis because of bloodstream or deep-seated organs or pathogenic fungi or pathogenic fungi can occur in immunocompetent individuals or immunosuppressed. Let's see about superficial. This is infection of the skin and mucous membrane. For example, pityriasis versicolor, tinea nigra, dermatophyte, candidiasis. This also includes infection of nail, that is onychomycosis, which is caused by candida or scopular sepsis, fusarium, tracheosporin species, aspergillus, or dermatophytosis. The clinical presentation of superficial fungal infections. It can be caused by dermatophytes, which causes either tinea facie, barbe, tinea corporis, tinea magnum, tinea cruris, tinea pedis, tinea unguiculum, tinea pedis, and tinea incognito. So, These are the images of the superficial fungal infections. When it occurs in the face, it's called fascia. When it occurs in the body, it is corporus. When it occurs in the foods, it is pedis. When it's on the nails, in the angunum, and when it is induced by steroids, it is incognito. How to diagnose this fungal infections? Either by gram stain of the swab of the lesion showing budding yeast cells and pseudohyphae, or by a KH mount of this sample from the lesion. What is the clinical presentation of superficial fungal infection? In case of hair, the infection of hair is called pythia, which can be either white or black pythia caused by dermatophytes. If it is caused in the head, it's tinea capitis. We can also see the head or head lice or nits, which resembles like pythia. How to diagnose fungal infection in hair? KH 10% is an ideal test which shows arthroconodia inside the hair shaft, which is a bag of black, which is like a bag of marbles appearance under 400 magnification. How to manage the superficial fungal infection? History examination, then antihistamines, topical antifungals, systemic drugs, barrier repair, or immune boosters. It all depends upon the clinical type, the skin with oily dry, use of steroids, and according to the antifungals administered like ketoconazole or cetaconazole or luriconazole or amphotericin B and others. The duration may be longer for 4 to 6 weeks. Superficial fungal infection is very difficult to treat, is it? Recalcitrant dermatophytosis may occur due to steroid abuse, lack of compliance, clinical type of infection affects the treatment or management, and the drug quality. Superficial infection of eye and ear. Of ear, it is called as otomycosis, and of the eye, it is called as keratomycosis. Otomycosis could be either because of Aspergillus niger or Aspergillus fumigatus or penicillium. Keratomycosis could be because of Aspergillus species, Fusarium or Ernonium or Purvularis or Candida species. Diagnose this in fungal infection by calculiflower white stain, which shows septate acute angle branching hyphae, as you can see from this picture. It is an acute angle, 90 to 90-degree angle, branched hyphae, fungal hyphae resembling Aspergillus species, or on corner scrapings, or a lactophenol cotton blue mount from the culture showing Candida or yeast. Treatment for ocular fungal infections: topical antifungal eye drops like natamycin or amphotericin B, and azoles like fluconazole or orinazole. Initially hourly and then taper over 6 to 8 weeks. Systemic antifungals like fluconazole or vonoprazole for 2 to 3 weeks. For ear infection, that is otomycosis, ear toileting to remove the discharge and debris, then topical antifungals like nystatin, clotrimazole drops for 1 week. We'll move to the next session. Thank you.